Looking around completely in awe because this event was an idea just 14 months ago. And we had an idea of producing a day-long, high-level, educational, interactive event for our community. You are our community. We serve you 365 days a year. And when we had that idea for Little Neuro Challenge to take on such a large event, there were so many questions. Well, who are you going to get to speak? Well, I think you see by the speaker lineup that we have some of the country's most exceptional experts in Parkinson's. And then they said, well, how will you pay for it? Well, I am happy to tell you we have 32 exhibitors here, and our sponsors are very generous. And the sponsors and the exhibitors who are here today, they are the reason that this event is being offered at no charge. The response for this event has been truly overwhelming. We have over 1,600 people registered today. So I'm going to say that again. We have over 1,600 people, empowered people with Parkinson's, registered here today. So we have a full day of education, engagement, and empowerment planned for you. So at first, we have a lot to celebrate. It's Parkinson's Awareness Month. And I would say, does anybody know that? But I think everybody in here knows that. And what better way to celebrate Parkinson's Awareness Month than over 1,500 people coming together to show our community that as people with Parkinson's and as caregivers of people with Parkinson's, that you want information and you want to live an empowered life. So I applaud every one of you for being here. You've sent the message loud and clear. I thank you for that. I also want to tell you that 2018 marks Neuro Challenge Foundation's 10-year anniversary. This is our 10-year anniversary of serving the local Parkinson's community. And I can tell you that we have only just begun and just scratched the surface. So we all play a role in supporting the Parkinson's community, and Neuro Challenge Foundation for Parkinson's is very proud to be your local Parkinson's organization that is here to support you year-round. I have to acknowledge all of the people who are here who have Parkinson's because you inspire us. This event was made for you. This event was also made with input from members of our community. I thank you for being here. I thank you for making the choice to live a positive life with Parkinson's. And I have to acknowledge the caregivers. Neuro Challenge Foundation's mission is to improve the quality of life of people with Parkinson's and their caregivers. Caregivers, we are here for you, and we salute and applaud you. I am now going to turn this over to who you really came to hear speak, and that's the experts. We hope you have a great day, and I'll talk to you a little later.
At this time, please welcome to the stage Dr. Lawrence Elmer from the University of Toledo, Ohio, to discuss motor symptoms and current treatments for Parkinson's disease. Dr. Elmo's bio can be read in the Expo program book. Dr. Elmer.
Thank you so much, Brent. And thank you, Tampa, Sarasota, Western Florida. You all know I grew up in Leesburg. Some of you know that. This is really like coming home. But I just want to say, good morning, Sarasota. Okay, now, before we get started with what I'm supposed to talk about, I really need to tell you This program, Neuro Challenge, because I have the honor and privilege of speaking all across this nation, this group is by far the best and the biggest I have ever seen. So I want all the volunteers, all the board members, anybody who's involved, Carissa especially, and Robin Fossey, stand up and please give them a round of applause because they are doing a miracle here. Working with you, they are changing people's lives for the better, and they are advancing knowledge, they are caring for you, and honestly, you all are breaking all the records. I cannot tell you enough. It is truly, truly amazing. It's my honor to be with you here on the 10-year anniversary of Parkinson's Challenge. So, anyway, if I could, if you're able to stand up easily, I'd like you to stand up, and I'm going to ask you to do two things. So please, if it's easy for you to stand up, go ahead and stand up. You know, we have a phrase among the leaders of Parkinson's disease. You all are the movers and the shakers. And nothing could be more true in so many different ways. But I want to salute you because you are here 9 o'clock in the morning on a Saturday morning to literally fill your mind up with information, and you've got a list of speakers that is second to none. But you, in turn, will then go and you will be a reference for other people with Parkinson's disease. People will come to you and say, what did you learn at that symposium? And you'll share with them and they'll get excited, and it's like the ripple effect. It just keeps going on and on and on. So I would like you, please, give yourselves a huge round of applause for being here and doing the right thing to learn about this disease, because damn it, we're gonna beat Parkinson's. We are not gonna let it beat us. We're gonna beat the crap out of this disease. And I'm going to show you how we're going to do that, at least to a certain degree. Now, let's get to business. Let's find out how we're going to beat this crazy, crazy Parkinson's disease. And like I said, you've got a ton of outstanding speakers today. You've got some real experts in this geographic area. Is Dr. Sutherland here yet? Dr. Sutherland? He'll be here. Dean and I actually went to school together at University of Florida. We both did our MD, PhD. The difference was I finished mine when I was about 32, and he was kind of like what was the guy's name? Houser, yeah, Dewey Hauser? Yeah, Dewey. He was kind of like Dewey Hauser. I think he finished his MD, PhD when he was like 14. The guy's just a kid, and every time I see him, I think, are you really a doctor? Or are you just masquerading as one? But he is unbelievably in tune with everything at the cutting edge of Parkinson's, and so are the other speakers you're going to see today. But my hat is off to Dr. Sutherland, because not only does he get to work with many of you, but he gets to work with Neuro Challenge. I said Parkinson's Challenge earlier, I'm sorry, Carissa. Neuro Challenge, because this disease, our understanding and the treatment options are moving at light speed. I tell people this is all I can do. I can barely keep up with it. And you're going to hear later about new treatment options that are in development. Ladies and gentlemen, all I can tell you is I've been doing this for 30 years. I have never seen so much progress in such a short period of time. And we are just going to blow the wheels off this thing. And what's most exciting is they're starting some very, very exciting new treatments to slow or stop the progression, which of course is what we all want. Correct? Correct. Okay. Did the timer start? Oh my, wait a second. It jumped. Okay. All right. So, just want to give you a little historical perspective. 200 years ago, last year, 2017, we celebrated the anniversary of Dr. James Parkinson's pivotal manuscript where he described the symptoms of Parkinson's disease. It was named after him like 40, 50 years later, and doggone it, he was an amazing surgeon who just through his powers of observation actually realized what the major symptoms of this disease were. And what I like the most is in his monograph, he said, and this is right from his monograph, on the contrary, there appears to be sufficient reason for hoping that some remedial process may ere long be discovered, by which at least the progress of the disease may be stopped. And we've been talking about, oh yeah, it's going to be in the next 5 years. Oh yeah, it's going to be in the next 5 years. I've been doing this long enough. I've seen so many 5 years come and go. I got to tell you, I'm getting tired and I'm getting old waiting for those 5 years to come together. But doggone it, it is happening, and it is happening in areas of all the brain disorders, whether you're talking about Parkinson's, Huntington's, or Alzheimer's. And there's going to be a little bit of an overlap because the advances we make in Alzheimer's and Huntington's could apply to Parkinson's and vice versa. All right. My responsibility is to share with you what are the primary motor symptoms that we deal with in Parkinson's and how do we treat them. Now, I could give a day-long seminar on this, so what I'm going to focus on is what are the major symptoms that many of us, and I got to tell you, we have a saying, you see one person with Parkinson's, you've seen one person with Parkinson's, because every single one of you is an individual. Every single one of you will respond differently to different medications. Every single one of you may have different side effects from different medications. And so it's our responsibility as your clinicians to try to find the right cocktail of medications to give you the best quality of life and to minimize the symptoms of Parkinson's to the best of our ability. And I always use that term cocktail because it's so socially inviting. It's just kind of like, so what's your cocktail for Parkinson's? Well, I take a little bit of Cinemed, and I got a little bit of Requip, and I got this other one, and then I just throw in a shot of Jack Daniels just for good old sake. And doggone it, boy, do I feel a lot better. Nowadays, people say, yeah, I take this, that, and the other thing, and then I put a couple drops of cannabinoid oil under my tongue. Oh, boy. All right. Now, this video is extremely old, probably 50 years old. Anybody in here see the movie Awakenings? Okay, that was a type of Parkinson's that was caused by a brain infection. This is what people with Parkinson's used to look like. Slow, shuffling, stiff, decreased arm swing. This was classic symptoms of Parkinson's. The slowness being the dramatic part, the short shuffling stride, the lack of facial movement, difficulty turning, freezing. I mentioned the decreased arm swing. It was really a horrible disease, and actually 30, 40 years ago, it was life-threatening. It actually was dangerous. It could shorten your lifespan. And nowadays, I will tell you, if you are under the right person, getting the right medications, and while I say this is not true of 100%, because nothing's true 100% of the time when you're dealing with human beings. Here he is on levodopa. What a difference a little bit of extra dopamine makes. And if we can find the right cocktail for you and keep that going, that will be the key to you managing your Parkinson's, but also keeping it as insignificant as possible. And I would say 90% of the time, the patients who are under our care do not pass because of Parkinson's. It's because of something else, you know, all the other things that hit us when we get older, cancer, heart attack, stroke, whatever. But if you're under proper management, doggone it, you should not have to deal, or you should not have to worry about the long-term complications of Parkinson's. I say that, I know that it's not true 100% of the time, but I guarantee you, compared to 30 years ago, it's like night and day. People are doing so much better. As long as they're getting the proper care, then they will not have to succumb to this disease as their quote-unquote final demise. So please, please, please make sure you are getting the best care from the best doctor, and you always keep up with it, because this is a disease that's progressive, so you can't stay on the same medication forever and expect it to work. And with that, I want to make two separate points. I got time. Okay, here we go. The first is, how many of you have heard that once you start taking carbidopa, levodopa, the classic Cinemet, that it only works for a certain period of time, let's say 5, 7, 9 years. How many of you have heard that? Please raise your hand. Okay, be brave, be brave. Yep, a lot of hands raised. I am here to tell you that is the most common fallacy that is being spread throughout the world of Parkinson's. My mother-in-law had Parkinson's for over 40 years. Even at the end of her life, she was still responsive to levodopa. The question is, can you tolerate the dose that you need in order to control the symptoms? Because you give the brain what the brain wants. You give the brain what the brain needs. And honestly, I have to tell you, it's very, I feel bad when people think they just want to hold off and hold off and hold off before they start levodopa. Why? Because despite all the great treatments we have, carbidopa, levodopa being the precursor to dopamine, is still the strongest and best medicine we have available for managing Parkinson's disease, bar none. It is the raw material that is converted to dopamine, and dopamine is the real McCoy. That's what we're trying to do. Okay, so what are the classic symptoms? Stoop posture, a little bit of shaking, lack of facial expression, shortened stride length. You know, sometimes people have tremor. Up to a third, maybe 25 to 30% of people will never have tremor in their lifetime. So that's why we have to look for that slowness of movement. Brady meaning slow, kinesia meaning movement. It's the top diagnostic criteria that we have to make a clinical diagnosis of Parkinson's disease. And one of the major breakthroughs that occurred, and I think I shared this last time I was here, is that in 2003 we realized that Parkinson's was not just a deficit of symptom of dopamine neuron loss. It actually affects almost every nerve cell in the body for some people. Not everybody has all the different symptoms that can manifest in this disease, but it was a breakthrough revelation when we realized that the disease process. How many of you all have heard of Lewy bodies? Okay, Lewy bodies. That's the pathological hallmark of Parkinson's disease. And we used to think they only existed in the substantia nigra, which is where the dopamine nerve cells are. Turns out Lewy Lewy body or Lewy neurites accumulate all throughout the body. And in many cases, not all, but in many cases, the first two places that they appear in our nervous system is in our olfactory bulb, where our sense of smell is located, and in our intestines, which is, basically everything that we breathe passes over the olfactory bulb. Everything we eat and drink passes over the lining of the intestines. And that strongly implicates an environmental factor in the development or the actual initiation of Parkinson's disease. So you'll probably hear a little bit more about this later, but I want to mention it to you because it's still something that is driving new research that we couldn't even have conceived of just 20 years ago. It is breathtaking, and we are identifying, I'm going to share that just real quickly with you, what are the premotor symptoms that are being looked at and how we can identify people who are en route to developing Parkinson's before they develop any symptoms of Parkinson's at all. But the problem is that disease, even though it starts in these two distant locations, continues to spread and over time can affect other parts of the nervous system. So when I was being trained, I thought Parkinson's disease was all about that substantia nigra, so-called substantia, body, nigra, black, the black body. It looks black on a brain cutting. And so we just sort of thought this was what Parkinson's was all about, stiffness, slowness, and shakiness. Well, turns out, we neurologists, we're out there in our speedboat and we are just driving along thinking this is what we're going to do. But unfortunately, we hit this iceberg and boo, right down to the bottom of the ocean because we didn't realize that the disease was so extensive and could cause so many different symptoms. For example, when I talked about these motor symptoms, well, there are other symptoms that can occur. And again, these will be discussed later on. Not everybody gets these, but some people do. And thank goodness there are treatments for these. Now, I'm only going to talk about motor symptoms and motor treatment today, but I think you're going to have some other talks about some of this stuff. Pre- and non-motor complications of Parkinson's are listed here. Oh, by the way, Carissa, I know this is being videotaped, so you'll be able to watch this. I highly recommend if you're experiencing severe insomnia, go to the Neuro Challenge website, pull up my video, you'll be asleep within minutes. Guaranteed. Guaranteed. Okay, so what we're realizing, and I put this little asterisk here, some of these symptoms, constipation, depression, anxiety, lightheadedness, pain, sleep disturbances, change in sense of smell, blah, 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 blah. All of these can be seen before Parkinson's symptoms occur, and many of them can be seen after Parkinson's symptoms occur. So this is the cutting edge of our understanding of Parkinson's disease, and it is going to allow us to identify people who are in the process of developing Parkinson's before the substantia nigra experiences any significant damage. And so the long-term goal is to identify, treat people who are en route to developing Parkinson's, and in a sense, prevent them from ever, ever, ever developing Parkinson's. And believe me, if that happens before I die, I will die with a huge smile on my face. That will be exciting beyond words. Oh boy, tell me about it. This is really, things are moving faster than you can possibly imagine. Okay, so I already mentioned the bradykinesia. There are certain diagnostic criteria. There's even an x-ray that we can do nowadays called the DAT scan. But here's the challenge. And we see this with all of our medications, but classically we saw it with levodopa. So let's just take just a minute on this slide. So basically this is to show this sort of narrowing little area, a little almost like a triangle. Basically it's to show that when you're early in Parkinson's, you've got a lot of substantia nigra neurons. So even though you take your medicine, maybe you forget a dose, maybe you take it with food or something like that, it still works because you've got a lot of buffer, you've got a lot of reserve, the capacity to kind of get over that little bit of a deficit with regard to the amount of dopamine. But as the disease progresses, sometimes the medicine, anything below this line is too little, so you would be in the off state, which is written here. And then if it's too high, That's the on state. That's like Michael J. Fox when he's got the wiggling movements. And then as the disease progresses, the amount of time that the medicine works gets shorter and shorter. You have more off time and you have more on time with dyskinesias. Ladies and gentlemen, I am here to tell you 30 years ago, this was a major problem. It has become less and less and less of a problem because of all the breakthroughs that we have made in the world of Parkinson's. So what's the difference between on and off? So here's a gentleman, seeing a colleague of mine, one of the best Parkinson's doctors in Texas, Dr. Richard Dewey. Actually was at a meeting with him in Denver last night. The problem was that the plane coming from Denver arrived late. I got in about 4 o'clock this morning, so if I pass out on the floor, just throw something at me and I'll wake up and start talking again. So, but you don't see a rest tremor in this guy, so he could be in his doctor's office and they wouldn't even notice that there was anything wrong with him. He looks a little slow. We call him Slow Joe. And they could be blamed on arthritis, could be blamed on aging, et cetera, et cetera. But Dr. Dewey is about to prove through the experimental use of a medicine that is commercially available now called apomorphine. It's an injection that it can actually stimulate the dopamine nerve cells in a way that acts just like dopamine. So you can see he's pretty slow, but his biggest problem really is getting up out of a chair and walking. And you'll see when Dr. Dewey asks him to stand up, he really has to struggle. In fact, if he was in a soft, deep couch, his wife would probably have to help him. And then you get in a very dangerous situation. Why? Because what happens if she pulls too hard and they both fall down? Both of them could break an arm or a leg or something like that. So that's where we want to try to avoid this at all costs. Finally, you see his tremor and his gait. He's walking very slowly. Kmart used to have those blue light specials, and if there was fishing gear in the back of the store, and they called a blue light special on that, I guarantee you all the stock would be gone before he got there. He is really struggling with his gait. Now look what happens. Now realize in this case, this is an injection. It only lasts about 60 to 90 minutes. It's marketed in the United States as a rescue medicine. But that said, Dr. Hauser will actually talk about some new developments with apomorphine. Now you can see the difference between when his dopamine was too low and now his dopamine is just right. He is much faster. He feels more relaxed. His voice would be stronger. He might have been having a little drooling before. Doesn't have that at all. And he's able to follow all these commands, and the speed difference is just dramatic. But the biggest difference is in his ability to stand up and walk. So let's just keep watching this video for just a second. Now, for some people, being off just means your tremor comes back. For other people, being off means you are pretty stiff and slow. You have trouble getting in and out of the chair. Watch him launch out of this wheelchair. Bam! He is ready to go. And now his gait, whoa, what a difference. Dopamine is at its optimal level, and I think he's ready to go out on the golf course. See you later, Dr. Dewey. I'm done. Going to go hit out, 9 holes. So this is our challenge, and this is the slide that I'm going to use in a couple different ways. So I want to explain it very briefly because it shows 2 different concepts. One, again, is this narrowing therapeutic window, which occurs over a period of years and years and years. And basically, as the disease progresses, you have less and less buffering capacity to be able to take the alternating levels of the levodopa and make them work. And then this is sort of a picture of the levodopa over a period of hours, how it can fluctuate in the bloodstream and in the brain. And early in the disease, it can be up and down, but you still feel pretty good. But as the disease advances, there's periods of time when it's too low, there's periods of time when it's too high, so you'd be off in this state, and then you'd be on with wiggling movements in this one. Now, if we were in the 1990s, levodopa would basically, 1960s, this would basically be the only thing we have. I mean, we got a couple other drugs, but dopamine, levodopa was the major breakthrough in the late 60s, marketed in early 70s, and had a huge dramatic impact, but unfortunately led to this sort of fluctuations. It is still the gold standard. It's changed the course of Parkinson's disease. And just to show you what a difference it made, these were studies done before levodopa. The rate of developing severe disability or even passing as a result of Parkinson's at the end of 6 to 10 years was over 60%. At 11 to 15 years, it was almost 90%. Once levodopa was introduced, those numbers dropped precipitously. Now it's maybe 20, 22%, and at 11 to 15 years, it's even less than 50%. And these are very old data. I would say the numbers are much, much less right now. So we're going to talk about these fluctuations. This is the dyskinesias that you see with Michael J. Fox. This is when there's too much medicine on board. And the problem here is that in the past, when all we had was levodopa, this was unfortunately a necessary complication we had to deal with. Well, times changed and we made the new medications. 1990s, there were some dopamine agonists added. There was an MAOB inhibitor added that prevented the breakdown of dopamine. And year 2000, they doubled the number of those medicines. And this is today's list. And I would go through this in great detail, but for some reason, this clock right here is on a time warp. I mean, I feel like I've been up here for 5 or 10 minutes, but it says I've been up here for almost 30 minutes. Can you believe that? Have I been talking for 30 minutes? I'm just going to ignore it, okay? Okay, all right. So, but just to go through, and we're going to talk about all the newer medicines, but just to give you an idea, and these slides will be available. I'll send them to Carissa. I apologize you don't have them today. But there's one thing that I don't want to forget to say to you before I leave here. There is one drug that I want you to put on your list of allergies. That drug is Haldol, spelled H-A-L-D-O-L. Haldol. Haldol is the most powerful antipsychotic ever invented. How does it work? It blocks dopamine receptors. So if you give it to a person with Parkinson's disease, you turn into a statue. And that statue state can last days, even weeks, as that stuff gets out of your system. And believe me, it is life-threatening. So if you can, please remember to put on your list of allergies Haldol. If they say, what was the cause of it? What was the problem with it? Did it cause a rash or something? They say, no, you don't realize. It could kill me. It could kill me. How do you know that? Because some doctor said, what was the guy's name? I don't remember. He was at some speaking engagement. But, basically Haldol is your enemy. And I unfortunately still see it used in too many Parkinson's patients. So why do sometimes the medicines work and sometimes they don't? Well, sometimes, you don't tolerate the medicine. Sometimes you forget to take it. Sometimes you take it with food, and most of you are familiar. All those of you who know that protein can interfere with the absorption of levodopa, please raise your hands. Okay, a good number of you. So we usually have people take their medicine, especially the carbidopa-levodopa, which is the only one that's affected. In all of its different forms, carbidopa-levodopa can be affected by protein. So we have you usually take your medicine roughly an hour before your meals, so it's not affected by the protein. Gastroparesis is slowing of stomach emptying and everything else. So, in fact, they've done a study, and believe it or not, lack of stomach emptying is one of the major causes for taking your first dose, and it doesn't kick in for an hour or 2 or 3. They've even identified some bacteria that eat levodopa for lunch. And so there's a lot of different factors in our GI system that can play a role in developing or losing the ability to respond to Cinemet. So let's talk about the recent medicines. I'm going to have to go through this in a whirlwind pace. One of the newest ones, which was released about the same time as the next drug I'll mention, is called Rytary. It was a new version which had little pellets. How many of you all remember the contact cold capsules that were like 1 million little cold tablets in one little capsule? That was the first 12-hour cold agent. And same thing with Rytary. They got all these little pellets. There's an immediate release, an extended release, and a super extended release. And this is what it looks like if you open it up. These are the different sizes. But basically, just to give you an illustration of how long this drug lasts, Here's regular Sinemet, it goes up and down the system. Here's Sinemet CR, goes up and down. Here's Stalevo, that's a combination of carbidopa, levodopa, and entacapone. And here's Rytaria, it goes up, stays up, has a second peak, and goes down over a period of about 4 to 6, maybe 8 hours. Now, it's still a brand name, so it's expensive in some cases, but some insurance companies pay for it. But you really need to work with your doctor closely, because we've struggled to find the right recipe, how to make the cocktail work. Okay, what about how else can we stabilize it? Well, we could give the Sinemet more often. We could give it every 2 hours, and that's what's shown here. These little peaks and troughs, that's pretty stable. But every 2 hours taking medicine, how inconvenient would that be? But compare that to the big peaks and troughs when you take it at 4-hour intervals. Well, you know, there's pluses and minuses. But what if we could deliver levodopa in a completely continuous fashion? Well, that was the breakthrough with something called the Duopa pump. This is a carbidopa intestinal gel. You have to get surgically implanted, a tube, so that's a big decision, but then you wear this device and it infuses the dopamine continuously, and this is an illustration of the dopamine levels, well, the levodopa levels in the bloodstream. So just like this slide right here, where it's basically the same all day long, we're seeing exactly the same thing with Duopa. So this is an option or an alternative possibly to deep brain stimulation surgery for some people. Thank goodness most people do not have to use this, but boy, for the people who need it, it is a godsend. It is truly a miracle. Okay, what about dyskinesias? Well, you've seen Michael J. Fox, and again, this is a symptom of too much medicine in the system. I am getting close to being done, so don't pull me off the stage yet. There was a brand new drug just recently released called Gocovri. It's actually an older medicine called amantadine, but it's very slowly released in the system, and by itself can actually block the dyskinesias without any other adjustment in the medication. And the key is that you take it at night, it stays very low until you start to wake up in the morning, you take your first dose, and then it stays just the right level to control the dyskinesias during the day. Now, what about those other pesky motor complications? Well, there's always deep brain stimulator surgery, and again, even though most of us don't ever have to consider that, some of us do, and it is, probably from my standpoint, closest thing to a medical miracle, but it is a surgical procedure. They implant these leads in your brain, they connect them to a pacemaker-like device, they turn it on, and you can see the effects in this gentleman right here. Here he is off of his medicine, off the electricity, classic symptoms of Parkinson's, shaking, stiffness, slowness, difficulty getting up out of a chair. His face is, lacks expression. He's probably drooling a little bit, and he probably has some postural instability as well. So he takes the very short shuffling steps, and so this guy, now normally when you have deep brain stimulator surgery, you don't go off all your medicine, but you're able to reduce it. But the real key is just like the Duopa, the electricity is in your system 24 hours a day, so you have pretty continuous benefit. Here he is with the electricity turned on, so electrical dopamine, no medications, which again is very rare. Tremors gone, his face has a more normal appearance, he's able to walk, and I think he thinks he's John Wayne reincarnated. I mean, he's just like, I am so cool, and I know it. And boy, oh boy, I just can't wait to get back to my independent living facility, because I've got my eyes on a lady. I'm going to go take her out for coffee. Okay, now this is my mother-in-law. I mentioned she had Parkinson's for 40 years. At 30 years, DBS was approved for Parkinson's, and so we took her over to Cleveland Clinic. She was like this most of the day. So she was like Michael J. Fox. She had to be on with dyskinesias. Otherwise, when she was off, she was miserable. Her right leg would stick out when she was off, and as a result, she'd have to sit in her wheelchair, and she'd push herself around with her good foot, the left foot, but that was her life. She really couldn't walk because of that severe sticking out of the leg. And so she had the DBS done in the summer of 2002. Here she is back in North Dakota where she lives. The wheelchair was in the closet. Come on. Here she is back in North Dakota. Wheelchair was in the closet. She was like this 90% of the day on 70% less medicine. And boy, oh boy, was she dramatically improved as a result of that deep brain stimulation surgery. Okay, the most recent drug that's released is called safinamide or Xadago, and this is similar to some of our other medicines, rasagiline and selegiline. They're called MAO-B inhibitors, and they block the breakdown of dopamine, so it allows it to be recycled. And it has some special characteristics, but again, it's one more tool in our toolbox. If those other ones didn't do you any good, maybe this would be something to try. It might actually give you some benefit. Now, here's the last point. We are now referring to Parkinson's-specific therapies, and I am so thankful that you all at the hospital, it's affiliated with Neuro Challenge, you all have virtually all the different therapies, the dance therapy, the boxing therapy, et cetera, et cetera. But the first one was called Big Therapy with Becky Farley. And this is a video of a gentleman who was struggling. He had trouble with, shortened stride length, and then he'd get in a position, he'd freeze, and he couldn't move his feet. He'd have trouble getting in and out of the car, so his wife was frustrated because he couldn't go into the restaurant or into the mall or into the theater or anything like that. And this video was taken, and his wife said he was just showing off that day. He's usually much, much worse. So then he went through the big therapy, and I'm telling you, this was in Southern California. This is not an actor, even though it could have been. This is the real guy. After 4 weeks of therapy, this is the way he wound up. I met him 6 months later, and he was still walking at this pace. Dramatic improvements, because we believe now that these Parkinson's-specific therapies literally change the connections in the brain, make new connections, bypassing the areas that are damaged by the Parkinson's, and as a result, significantly improving the symptoms. So the medications, the cocktail, along with the exercise, go together. The two together are far more powerful than either one by themselves. Okay, the most important prescription of all, and why you are here today, hope. And I want to leave you on that note. Thank you so much for your time and attention.
Thank you, Dr. Elmer. Please welcome to the stage Dr. Ramsey Andrew Faulkner.
Thank you, sir. Okay, I'll come on
From the Innova Medical Group, Falls Church, Virginia, to discuss identification and treatment of the cognitive and behavioral symptoms of Parkinson's disease.
Yes, sir. Hi, everybody. Good morning. I am going to try to follow up with the same level of excitement and energy, but you have to cut me a little slack. I have two beautiful children at home, a 3-year-old and a 6-month-old. So my wife and I have forgotten what that whole sleep thing means. And so last night, I slept for 7 hours straight for the first time in about 6 months, and I'm seeing colors for the first time right now. So my brain is getting different signals that it doesn't know what to do with. So if I start acting crazy, somebody just throws something at me, it's because I actually slept. Well, I want to thank the Parkinson's Expo team, the Neuro Challenge team, for inviting me to come speak with you. This is a wonderful opportunity because as you're discovering Parkinson's disease, the symptoms of Parkinson's, what we think about Parkinson's disease, are a little bit off with how we should expect to have the disease. How we treated Parkinson's 20 years ago is completely different than how we treat it today. And it's absolutely the truth. We see it every day in our center in Northern Virginia, that if you take a patient who's been exposed to one medicine or is being treated like we used to, and you just take these principles of updated, smoother, more consistent therapies and you apply them, it's like night and day. People will wake up for the first time in 10 or 15 years. It makes it fun to treat Parkinson's these days because we can actually make people meaningfully better for a long time. And part of that is being educated. Part of that is the fact that a Parkinson's patient is dedicated to beating their disease, seeks out information, has a wonderful team of support and caregivers around them. And with that education, then you get to be your own advocate for what is better. So thank you for you guys for actually coming out to learn about your disease, because that's as much the ticket to getting better as the medicines that we have. But on a different note, we're going to talk a little bit about the cognitive changes that go along with Parkinson's, Parkinson's dementia, Lewy body dementia. I think it's important. It's not a topic people like to talk about, but it's one that knowledge is always power. You guys good with that? Good. So, where we're going to start is first with why. Why do the dementia symptoms of Parkinson's happen? And they don't necessarily happen for everybody. I know there's a commercial on TV by one of our good industry sponsors who talk about 50% of patients with Parkinson's can have hallucinations. Have people seen that commercial? It is all the talk up in Northern Virginia because, to be honest, that number freaked people out. It's not necessarily the case for everybody. So while this doesn't apply to everyone, it's good to know. So we're going to start with why. Why goes back to those Lewy bodies, those little proteins in the brain that develop in the cells that are trying to produce something, and they develop and they damage the cell. For Parkinson's disease, for Parkinson's dementia, for everything involving the disease that you are fighting, you have to think about it as a deficiency. You have to think about it as a production problem. That the factory that is in your brain that is designed to produce something, dopamine, acetylcholine, these chemicals that our brain needs, the factory is broken. And the factory is broken because these proteins called Lewy bodies collect in them. And the Lewy body is sort of like a hefty bag in these cells. It's designed to collect protein that is misfolded, protein that the brain can't deal with. And when these cells can't deal with it, they put it into the hefty bag called a Lewy body. And when the bag gets big enough, it kills the cell and moves on to the next one. And in fact, this is a pathological slide. And here's the cell, and this big circle in it is the Lewy body. The reason why this is important is because it's all about location. When you buy a house, we recently did, and that's always a fun adventure. The thing I heard about 1 million times from our realtor was location, 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 right? In fact, I think our realtor said it, location, 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 location. He said you could tear down the house, you could remodel the house, but you can't move the land, right? Has anyone heard that? Right. With Parkinson's and with these Lewy bodies, it's all about location. To build on what we were talking about earlier in that wonderful opening talk, there's a lot of research that says that those Lewy bodies start elsewhere, that we can actually detect Lewy bodies in the skin, in the gut, in the nose, before they travel up to the brain. Meaning, this is what's exciting, is that we've sort of identified that maybe this pathology starts outside of the brain. And so if we can catch it then, that might help delay the progression of the disease. Now with Lewy body dementia, it's all about location of those abnormal cells. At the very bottom of the brain, there's a nucleus called the substantia nigra, which is the factory that produces dopamine. When that factory gets filled with Lewy bodies, your dopamine level drops. With Parkinson's disease, once that production drops about 70%, so a pretty significant drop, you then develop the motor symptoms that you expect with Parkinson's, the tremor, rigidity, changes to gait. Well, interestingly, that substantia nigra is at the very bottom of the brain. If this is your brain, it lives out at the very bottom part. Well, the bottom of the brain is a very dense area of real estate. There's factories for everything at the base of the brain. It's the inflow, the outflow. It's where all the pathways for the body travel through. And there are two houses that are on the same block. One is the substantia nigra, that is the factory for dopamine. You get the Lewy bodies in there, you get the motor symptoms of Parkinson's. But a block or two over, so millimeters at the bottom of the brain, there's a different factory. And it's a factory that produces a chemical called acetylcholine. Now, acetylcholine is a different neurotransmitter. It does a lot of things in the brain, But the main thing it does is it helps with cognition. So for instance, Alzheimer's dementia is due to an abnormal response to acetylcholine. Lewy body dementia and Parkinson's dementia are due to an abnormal production of acetylcholine. The idea being that if you have Lewy bodies that aggregate in the substantia nigra, you get Parkinson's. If those Lewy bodies migrate a millimeter or two over and attack the factory for acetylcholine, you get Lewy body dementia. And it's an important factor not only in diagnosis, but also in treatment. You guys doing okay with me so far? I'm trying not to dive too deep because I think treatment is really the important part, and we're going to get to that, okay? So that brings us to what is Lewy body dementia? What is Parkinson's dementia? And one thing that we're going to go through is the idea that there really isn't much difference between Lewy body dementia and Parkinson's dementia. Pathologically, they're almost identical. Symptomatically, they're almost identical. The difference is time. If you develop the symptoms of Lewy body dementia or Parkinson's dementia early, usually within a year or two of the motor symptoms of Parkinson's, we tend to call it Lewy body dementia. If you develop the dementia of Parkinson's later on, 5, 10, 15, 20, 30, 40 years after symptoms present, we call it Parkinson's dementia. But really, to us clinically, the pathology, the symptoms, how we treat it is kind of the same. So, interestingly, 30% of dementias are Lewy body dementia, second to Alzheimer's. So it's actually a pretty sizable population. 1.4 million people worldwide have Lewy body dementia. The symptoms are what are important, and it goes back to treatment. It goes into this algorithm of how we handle this. And the symptoms are really either early or late cognitive change. That's the difference between Lewy body and just Parkinson's dementia. And the hallmark is actually hallucinations. Part of why hallucinations happen with dementia with Parkinson's is because you're also affecting dopamine. It's this interplay between the two hormones that are not working well. And if you want to take it a step further, patients who have diseases such as schizophrenia, bipolar disorder, neuropsychiatric conditions that we classically think about with hallucinations, those diseases are also a product of dopamine not working properly. So if all of a sudden you have a syndrome like Parkinson's that's dealing with dopamine being off, and we're giving you artificial dopamine, and then you start to affect the circuit for memory and cognition, hallucinations are all part of the deal. So classically, we think about dementia with hallucinations with a Parkinsonian component, because you need to have Parkinson's to have Lewy body dementia or Parkinson's dementia. And I can't tell you the number of times that a patient will come to clinic. In fact, I'm thinking of a lovely 86-year-old lady last week who came in with a diagnosis of Lewy body dementia, being treated marginally okay, but she was convinced that she didn't have Parkinson's disease. And her doctor actually told her, oh, you have Lewy body dementia, you don't have Parkinson's. And so God bless her, no one had treated the motor symptoms of Parkinson's for her. They were only focusing on the dementia. Remember, to have one, you have to have the other. Here's another interesting point. REM behavioral sleep disorder is a sleep problem that goes along with Parkinson's. I'll ask for a show of hands if anybody, or actually from the spouses, who here, their loved one at night will act out dreams, kick, punch? It's sort of like they're running from a bear, or they think you're a robber, or exactly. So don't forget about REM behavioral sleep disorder. It's actually a disorder of sleep. When we sleep, when we dream, our body is supposed to be paralyzed. We're supposed to, you know the old adage, the brain is awake, but the body is asleep? Well, with Parkinson's, because of the alteration in all of these neurotransmitters, the body doesn't become paralyzed, and people can kick, act out in their dreams, swing, and it's not pleasant for the bed partner, of course. But it also means that you're not getting the restorative sleep that you think. If that's happening and you haven't brought it up with your provider, please do so. Because you would be shocked that once you treat that, which is very easily treatable, you sleep better, you wake up better, and the person's day becomes better because you've identified and fixed a problem with sleep. Now, REM behavioral sleep disorder is a diagnostic criteria for Lewy body dementia. It's part of affecting acetylcholine and dopamine. Now, don't worry, if you have it, it doesn't mean you're going to get dementia. In fact, I will talk out of my sleep sometimes, but that doesn't mean I'm going to get Parkinson's or Lewy body dementia. But if you have Parkinson's or Lewy body dementia, the vast majority of people have that, and it has to be treated for people to be better. So, just to drive home a point very quickly, I want you to look at really, they all kind of reflect it, but really this set of images right here. These pictures are different studies comparing Lewy body dementia to Parkinson's dementia. This scan deals with the dopamine uptake system. This is Parkinson's dementia. This is Lewy body dementia. This is the amount of energy the brain needs or the deficiency. This is Parkinson's. This is Lewy body. And this is another reflection of how the body deals with not having enough acetylcholine. And the point of this is that Parkinson's dementia and Lewy body dementia are exactly the same. The energy uptake is pretty mirrored to each other, so's the dopamine utilization. Again, bringing home the point, first, that you have to have Parkinson's to have Parkinson's or Lewy body dementia, and second, that the only difference between the two is time. Now, people always tend to bring up Alzheimer's disease, because Alzheimer's is the thing we all fear. It's the thing that is debilitating to us as humans, and it's this scary thing in the future that robs people of everything. But Lewy body dementia and Parkinson's are very different. And it's actually a difference that works in your benefit if you have the Parkinsonian variant. If Lewy body dementia and Parkinson's dementia are due to the factory that produces acetylcholine being broken, Alzheimer's is due to the structures being broken. It's the difference between being a structural problem versus a chemical problem. When your body produces acetylcholine at the bottom of the brain, it goes out into the various parts of the brain to affect memory. Alzheimer's is a problem with where the chemical's going, not necessarily production. Parkinson's dementia is a production problem, not where it's going. Meaning, if you can fix the production problem, patients with Lewy body dementia and Parkinson's dementia tend to respond a lot better to medications than Alzheimer's patients. And this illustrates that. So this is the gray matter loss of the brain. It's how the structures of the brain shrink with these disorders. And with Alzheimer's, you can see on the sides of the brain, the red is shrinking. Just think about it as, you heat up the saran wrap and it shrinks. With Alzheimer's, you get real structural reduction on the targets that the chemical's trying to go to. But with Parkinson's dementia, Lewy body dementia, there's barely any at all. Meaning the highways are intact. We're just having a production problem. I'm trying to beat that home because it makes the treatment make all that much more sense. Are you guys with me so far? Okay, it's a little technical, but we're gonna jump into what we can do about it. So the final reinforcement of that idea is, again, you have all these nuclei at the bottom of the brain, and the Lewy bodies come up this nerve and start to propagate through. If you hit the dopamine one, you get Parkinson's. If it spreads then to the green one, which produces acetylcholine, look how close those two are next to each other, red and green. Then you get Parkinson's dementia. So how do we treat it? This is the part that people tend to get close but miss the ball a lot of times. If the problem is that you are not producing acetylcholine, if the chemical is low, if you're a deficiency, if you're the car that the tank is on empty, then what's the best way to do it? Fill the tank back up, right? Well, with Parkinson's, we can do that. We can give people all the dopamine we want in 1,000 different ways and people get better. The problem with acetylcholine is if you give someone a high dose of that medicine, it does terrible things to the body. Our body does not tolerate supplementing acetylcholine back. So what do? Well, the medicines we have boost the acetylcholine you're still making by blocking the breakdown of it. The idea that if your brain is a bathtub and we want to keep the water that's already in there in longer, one way to do it is to clog up the drain, right? As I got a text from my wife right before I came on saying the washing machine was broken and the tub was clogged. So, kids. But we have two ways to fix the imbalance with dementia. One is we can increase acetylcholine. We can do that by blocking the breakdown. The other is something that we discovered about 20 years ago. And this idea is that if the brain is existing with a reduced level of dopamine, well, all of a sudden the brain's kind of smart. It has a bunch of safety protocols in place. And one thing the brain does is it starts to kind of run on overdrive. It's kind of like it puts nitrous into the gas tank, it just floors the tank, it puts your car into sport mode, if you will, which, God bless my mother, once she discovered sport mode in her car, it's been dangerous ever since, so don't go to South Louisiana. But the brain does that by stimulating the major stimulatory neurotransmitter called glutamate. So it's a seesaw, it's an imbalance. It's that acetylcholine is low, and this stimulatory hormone, glutamate, is too high. So all of a sudden, the chemistry of the brain changes, and it's trying to function in a deficient environment, and it's trying to fix it by burning on all cylinders. Well, that tends to make things worse faster. So to fix dementia and Parkinson's, we have to boost acetylcholine, and we have to drop glutamate. And we can do that with a lot of medicines that we have today. So let's start off with the ones everybody knows and loves. These are the medicines that are called acetylcholinesterase inhibitors. They're the medicines that block the breakdown. They clog the drain in the bathtub. There are 3 of them that are available. Aricept, donepezil, which most people know and love. It's been around forever. It's a pill. Then there is rivastigmine or Exelon and galantamine. These work again by blocking that breakdown of acetylcholine, boosting it and helping cognition. It tends to work better in Parkinson's patients than Alzheimer's patients. The one I want to point out is Exelon, rivastigmine. So donepezil is the one everybody knows. It works relatively well. But Exelon does the same thing and is actually FDA indicated for Lewy body dementia. Fascinating to know that donepezil is actually used off-label for Parkinson's dementia, and that rivastigmine is the medicine that the FDA approved for this condition. I tend to like it a lot in Parkinson's patients, and I'll tell you why. It comes in a patch form. Donepezil is a pill, galantamine is a pill. There is a pill version of Exelon, but there's also a patch. I'm going to ask for another very brave raise your hands. Raise your hands here if you have constipation, slowness of your gut, or problems with digestion in Parkinson's disease. And everybody is just being shy because it's usually about 80% of people. Well, remember, we are limited in how we treat with this disorder, with everything we've got, because the pills you take have to get into your stomach, exit the stomach, go through your intestinal tract, be absorbed, and go to the brain. If we can bypass that, then we take the whole gut effect out, right? Kind of makes sense. It's one of the reasons why I use a lot of the Neuro patch, which is a dopamine agonist. It's not for everybody, but in the right circumstances, it lets us bypass the gut and give smooth and predictable therapy. Well, Exelon does the same thing. It's a patch. So it doesn't go through your gut. It doesn't go through your GI system. It just goes into your system and works. And people tend to tolerate it a lot better than especially galantamine, which tends to throw people for a little bit of a loop. So it's a good option to try to help boost acetylcholine in the brain. Now, the other side of the seesaw is that other stimulatory neurotransmitter. It's sport mode for the brain. It's the thing that has my mother being on the radar of all the police in Southeast Louisiana. It works by blocking this transmitter, this channel called NMDA. That's why the trade name is Namenda, because it blocks NMDA. Clever, right? They thought they were. It tends to correct the overexpression of glutamate, calming down the excessive transmission, making the brain more balanced. Interestingly, there's been a number of studies that it doesn't really do much early. And if you think about what we talked about this being the brain's response, it kind of makes sense. Early on, the brain hasn't kicked into sport mode yet. So if you give somebody Namenda or Memantine early, it doesn't do much. But for moderate or later on dementias or dementia conditions, this tends to restore the balance and actually can not technically slow down the disease, but it gives a degree of stability to the disease. Fascinatingly, and we've seen this a lot in the Parkinson's community, it's very structurally similar to amantadine, even Gocovri. So amantadine, memantine, they sound kind of similar. And in fact, this baseball cap is amantadine, and this one is Namenda, memantine. So I find that a lot of my moderate dementia patients with Parkinson's disease are also having trouble balancing out their medicines because things are a little advanced. If we add memantine to the mix, it stabilizes the cognition to a degree. And of course, not everybody's the same, but that's our blanket statement. But it tends to stabilize cognition, and it actually, I've seen, slows down the dyskinesia and hyperkinetic movements that we would also be using amantadine for. So it's a good option for folks. And then this medication came out about 2 years ago by the maker of memantine. So Namenda, the same company, decided they were going to buy the rights to Aricept or donepezil and make a capsule that does both. Namzaric is a good medicine for folks who need simplicity and need smoother, more predictable delivery. So classically with donepezil, you're taking 1 pill a day. Classically with Namenda or memantine, you're taking 2 pills a day. Well, Namzaric is all of that in 1 capsule every morning. You can also open it and sprinkle it on applesauce or yogurt or other things to make administering it easier. So I use this agent for folks who have issues swallowing somewhat, for folks who taking 3 pills a day is a little bit of a barrier to things. And I've been actually switching a lot of patients to this because smoother, more predictable is where we're going across the board. And I find that this is a much better tolerated formula than the medications by themselves. You guys with me? Beautiful. How are we doing? Am I losing anybody? Everybody awake? Should we do a stretch session? We could all get on the bikes. It'd be fun. So I next want to shift gears because we've talked about how to treat the chemical problem at the basis of the disease. Now we're going to talk about how to treat the symptoms. The symptoms of Lewy body dementia, for those that are struggling with it, aren't pleasant. We're talking about hallucinations, paranoia, delusions, misperceptions. It runs the gamut of all of our worst fears. As we talked about earlier, the problem with hallucinations, paranoia, on down the line, is that before the past year, the only way we had to treat that was using older antipsychotic medicines like haloperidol, risperidone, even quetiapine or Seroquel, but they work through blocking dopamine. Again, think back to that schizophrenia analogy. We all think of, if you say hallucinations in medicine, the first thing people think is schizophrenia, right? That schizophrenia is due to dopamine inappropriately working. So for the past 60 years, science has worked to block dopamine to make hallucinations better. Well, what do you think happens if you acutely block dopamine in someone who's not producing enough dopamine? They do terribly. You would then be trading cognitive stability and hallucination reduction for mobility. And I can't tell you the amount of times that I've had patients come into clinic on haloperidol, quetiapine, any of these old antipsychotics, and they are locked up in a wheelchair. And we treat their hallucinations differently, and they start walking again, because it's purely a medication problem. Well, Nuplazid, Pimavin, they're probably back there, and I'm going to butcher how it is because I can't pronounce these names anymore, is a medication that came out 1.5 years ago specifically for Lewy body dementia patients, specifically to make hallucinations, paranoia, and misperceptions better. And it does it by not touching dopamine at all. It just blocks serotonin, a different neurotransmitter in the brain that can cause hallucinations, paranoia on down the line. And it does it beautifully. If you check, this is the chart from the literature. If you look at about 4 to 6 weeks out, you're talking a 40% reduction in all of those bad things, and I would dare say that it's even higher than that. The 2 things to remember about Nuplazid for those that have read about it or seen about it. First off, anytime we mess with serotonin, it takes time. If you notice at 2 weeks, there's no difference between placebo and Nuplazid. These patients, it takes a good month before this medicine kicks in. And you have to preach patience Otherwise, people take it for a week, think nothing changes, and then it's over with. I'm telling you, you take this medicine, and for most people, at week 3 or 4, I stopped getting phone calls, I stopped getting messages, because it's like a switch went off, and all those delusions and paranoia and hallucinations just get better. Now, the other catch, has anybody seen the recent CNN news on Nuplazid? Nope, Nuplazid is going to hate for me bringing this up, but that's why I'm doing it. So recently, it was last week, there were some reports of the possibility that there might have been some deaths somewhere related to this medicine, and it brought into question the FDA and how they put it through the FDA. I would say if you hear about it, proceed with caution in terms of the news reports. The reason why I say that is because all the other medicines that we treat hallucinations and paranoia with have a black box warning for essentially death. It's no fun, but it's the truth. And where it comes from is that these medicines we're using in very advanced, very sick people. So it's about balancing the risk and the reward. It's about balancing the literature we have versus the benefit we can give with these medicines. So again, part of it is having a specialist be part of your team. You guys with me on that? We good? Okay. So I wanted to shift gears just a little bit and talk about orthostatic hypotension. Does anybody know what this is? Anybody? So orthostatic hypotension is the idea that when you're sitting down, your blood pressure is a certain level, or lying down, for instance, and then you stand up and either right away or you start walking and your blood pressure tanks. It's those people that when they stand up, they get lightheaded or dizzy and have to sit back down. It's the people that they stand up, they start walking, and a minute later they get lightheaded, dizzy, and could fall. Does that happen to anybody here? Yes, exactly. It is a hallmark symptom of Parkinson's disease. The reason why is it goes back to the chemicals. I'm a very chemical-driven person because all we're trying to do is affect chemicals in the brain. There's a chemical in the brain called norepinephrine. You need dopamine to make norepinephrine. So if one is low, the other is low too. And guess what happens when your norepinephrine level is low? When you stand up, when you go to move, your body's natural response to increase your blood pressure, to increase your heart rate, stops working. And so if you were to monitor someone's blood pressure when one of these episodes is happening, their blood pressure tends to drop significantly, and their heart rate doesn't change. So if all of a sudden you're from sitting down to standing up, I know for me, I'm about a foot taller. For the actual normal height people in the world, it's like 3 feet taller. There's more gravity to overcome. The blood pressure doesn't push more blood up to the brain. And so all of a sudden, people become lightheaded, dizzy, and could fall. I'm talking about this with dementia because I have had an incredible number of people that were called dementia, but in fact had orthostatic hypotension. If you're not getting blood to your brain consistently, guess what? You're tired, you're foggy, you have problems with focus and attention, you have problems communicating. And what does that sound like? It sounds like dementia. So please, if you have these issues that we're talking about, make sure you check and see if orthostatic hypotension is a part of it, because fixing that has been shown to make the cognitive issues better too. And there's a wonderful medicine called Northera. It's been around for, I guess, 3 years now, that works not by forcing the heart to beat faster like the older medicines, but it actually works by boosting norepinephrine. And so it improves orthostatic hypotension by fixing the chemical that's the problem. And there's an ongoing study right now trying to measure cognitive change by fixing this, and I think the results are going to be shocking to us all. So keep that one in your toolbox too. Here's my avoid slide. So remember this. If we're dealing with chemicals being altered, chemicals being off, then putting other chemicals into your body can affect it. The one I'm going to jump to right away is an older medicine called Artane, trihexyphenidyl. Another brave volunteers, has anyone heard of this medicine or been on trihexyphenidyl or Artane? Okay, write this one down next to haloperidol. It is a medicine that before we had dopamine, before we had Sinemet and levodopa, was kind of one of the only things we had to fix Parkinson's disease. The trade name is Artane, the long name is trihexyphenidyl. I can never spell it right because I don't use it. The reason why I don't use it is because it works by blocking acetylcholine. So before dopamine, before levodopa, if you blocked acetylcholine in the brain, it would improve the tremor, improve the gait, improve the symptoms of Parkinson's. And there are a lot of providers out there who still use trihexyphenidyl artane to treat Parkinson's disease. Well, what do you think happens if you give someone a medicine that blocks acetylcholine, and dementia with Parkinson's and Lewy body is from not making enough acetylcholine? Anybody? You get cognitive symptoms. You have issues with dementia. And if you have patients on trihexyphenidyl, I guarantee you, if you ask the provider, he'll find that at about year 5, those patients will start to exhibit the signs of Lewy body and Parkinson's dementia. Well, we have patients all the time who come to our center on artane, trihexyphenidyl, and donepezil or Aricept. Now, for the chemical nerds out there, does that make any sense? One is boosting acetylcholine and the other is blocking it. No, it doesn't. And for these patients who have a terrible diagnosis of Lewy body dementia, for a lot of them, we stop both medicines and they actually become normal again. The other thing, like we talked about, are the neuroleptics, so the old antipsychotics that block dopamine. Cold medicine and anti-nausea medicines are things to keep on your list. They tend to work through blocking dopamine and also affecting acetylcholine and serotonin. And so a lot of patients with marginal, some little cognitive changes that happen with age and Parkinson's, they take dextromethorphan, cough syrup, and they all of a sudden become loony and they hallucinate. It happens. So stay away from cold medicines. And one more thing I'm going to point out with this slide before we talk about depression is that, remember, the medicines we're giving you for Parkinson's are boosting dopamine in the brain. Hallucinations, paranoia, can be a product of too much or inappropriate dopamine. Part of getting better with Lewy body dementia is balancing the cognition and the motor symptoms of Parkinson's. Well, you have to address the motor symptoms. I guarantee you that, and I see this all the time, that patients on very pulsatile, very up and down, high dose, classic levodopa medications who have dementia, hallucinations, paranoia, are benefited a millionfold by being changed over to smoother, longer acting, more predictable medicines, or at least regimens that don't slam the brain with dopamine through the day. In fact, one of the symptoms of too much medication, of the medicine being slightly supratherapeutic, is dyskinesia, that writhing movement that we see with Michael J. Fox. It's also hypomania, so those patients that talk a million miles an hour and they just feel like they're doing great and they feel fabulous because you're just overstimulating their brain, and also hallucinations. And remember this too, dopamine agonist, that other category of Parkinson's medicines, Mirapex, pramipexole, ropinirole, Neuro, they run a higher risk of causing hallucinations as a side effect. So before diving into all these medicines, I always say let's try to maximize and improve the stability of your Parkinson's medicines to see if we can make it better. You guys understand that? You with me? Okay. We're rolling into the end here. I wanted to bring up depression and anxiety. Because if you think about somebody who is with memory issues, we think of memory issues as this blanket statement. Well, what is memory outside of the retention of information? So I would guarantee you, if you take someone who comes in and says, well, my spouse or the patient themselves says, I have problems with focus, I have problems with attention, I have problems retaining information, my wife will tell me something and 5 minutes later I can't remember it. If you say, well, this person might be a little depressed versus dementia, you could make the same argument. The reason why I say that is that depression is prevalent in Parkinson's disease. This was a study from 2010 that said 60% of Parkinson's patients say they have depression, and I would guarantee you that the other 40% were just too shy to talk about it. When you're dealing with dopamine that makes you feel good, of course there's going to be depression and anxiety involved. Depression is a masquerader for dementia. If you don't address depression and anxiety, you're not treating the source of the problem a lot of the time. So please keep this on your docket, that if you're having issues with memory, especially short-term memory, please try to address depression, because that could be the reason rather than actual dementia. You guys with me? This one's really important because people tend to miss this one. Now, I wanted to bring up one more medication and one more syndrome, and then I think we're done because I'm getting the bright red light that's blinking at me. So So who here has heard about pseudobulbar affect? It's a terrible name. It goes back to the 1800s when they named things sillily. Is sillily a word? I just made it up. That works. So let me tell you real quick about what pseudobulbar affect is. First off, I'll tell you it's very prevalent in Parkinson's disease. The original study, PRISM study, showed that 26% of people had this symptom. And in fact, we did a study in our center where we just screened everybody, and our numbers were 40%. Pseudobulbar affect, to me, is like emotional incontinence. It's the kind of thing that is socially debilitating. It's the kind of thing that people don't go out because of it, avoid social situations, and it's the kind of thing that people don't want to talk about. If we talked about urinary incontinence, everybody here would run to their urologist because they wanted to fix it, right? Well, urinary incontinence is socially debilitating. It keeps people from going out. It limits your ability to enjoy life. But emotional incontinence is a similar thing, but people don't talk about it. So in a neurological condition such as Parkinson's, such as stroke, such as ALS, any of these alterations of the brain, the thermostat for emotion can get broke. A patient, this is a symptom of the disease, pseudobulbar affect. And it's that patient who, when you're in clinic or the family tells you that they're very quick and easy to cry, maybe appropriately, but it's a heightened response, or maybe inappropriately, where it's something that really shouldn't make, like the grandkids come over and grandpa just starts bawling when the grandkids come twice a week. This was a patient last week. Or it's somebody who it's laughter, where they'll laugh inappropriately or tell an inappropriate joke and laugh too much. It's a symptom where the thermostat is broken. And if you could imagine, it's a very socially debilitating symptom that people don't talk about. The reason why I bring it up is because there's a medicine now called Nudexta that works beautifully to drop the episodes by 70%. 70%. If we were in urology, well, first off, I'd have a very different life, I would presume. But if I said I have a pill that makes urinary incontinence 70% better, everybody would be lining up to talk about it, right? Well, people don't talk about pseudobulbar affect because it's uncomfortable to talk about. But I just want you to know that there is a medicine that reduces those spells by 70%. And I have seen that it can be life-changing because it makes people more comfortable in social situations and going out. So keep this in your toolbox too, please. So what else can you do? And then we're done. Activity. Please, 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 please. If there are any physical therapists in the room, God bless you. You do more to make these patients better than I do. For rock steady boxing, cycling, for all the resources you have through the Neuro Challenge, God bless them. And for those that do it, you know the difference exercise makes. For those that don't, trust me, I would stake my entire everything on the fact that if you exercise, you will do better and feel better. The limits of what we have medically is that we are artificially creating hormones that you take, get into your gut, go through your system, and push into the brain. Guess what exercise does? It naturally overproduces dopamine, serotonin, norepinephrine, and also neurorestorative hormones. Exercise is the best medicine for everything you got. And if you aren't exercising, we now have studies that show that at year 6 to 8, it's the difference between wheelchair and walking. So please exercise, it makes everything better. Healthy diet, you gotta eat well. There's no specific diet that helps with cognition on down. People will talk Mediterranean diet is very good. I tend to say, just listen to all the things your mother told you when you were young, eat leafy greens and a balanced diet and exercise and you'll be better. There's no real strong evidence for any of these supplements, including coenzyme Q10. So my approach to supplements is, if it's not gonna hurt you and it's not expensive, why not? Go for it. And so a lot of my patients are on supplements, they do acupuncture, they do meditation, all good for you as long as it's not breaking the bank and you think it's good for you. And so my conclusions are memory, cognitive function, and mood are directly linked to chemical problems. It's a chemical problem. You have to address and treat the chemical problem to make it better. Proper diagnosis is incredibly key. If you have Parkinson's dementia, Lewy body dementia, you have Parkinson's too, and so you have to treat both. And if one side of the seesaw is boosting dopamine and the other is reducing or blocking acetylcholine, you have to do that in balance because one can make the other worse. So that takes me to integrating a movement specialist. For those that don't see someone with specialty training in Parkinson's or dementia, please go find one nearby. And I'm not talking somebody who does it for a hobby. I'm talking about having someone in addition to your neurologist who just does this. The landscape of therapies that we have to treat all of these symptoms are growing by the year. We've had, I think, 6 medicines in the last 3 years come out for Parkinson's, and in the 50 years beforehand, it was 6. And we probably got 15 coming out in the next 3 years. And they're all designed to fix the problems with the medicines we have or to treat it smarter. You have to have someone who knows what's going on to really take advantage of what science is doing for you. And the unfortunate truth about it is it usually takes about 10, 15 years for new knowledge to reach the community providers. They're doing the best they can. They're wonderful. I love our neurologists in Northern Virginia. But they're supposed to be jacks of all trades. And the textbook on Parkinson's and movement disorders is now about that thick. And 20 years ago, it was that thick. So please integrate somebody like me, one of these movement specialists, into your care, and you would be surprised how much better you could do. And that's us. We're in Northern Virginia. If you're ever up in the neighborhood, look us up. We have a giant movement center up there. And I was only 7 minutes over. How was that? Good. That's all I got.